So it was at Pittsburgh that I started translating to the clinic our discoveries in the lab. And while it's difficult everywhere. And if you compare, other than financially, Pittsburgh is not a wealthy school. So if you want to do something, you have to find the money to do it. And the money is not going to come from the university. But what is so amazing in Pittsburgh, and what really made me want to be there, wasn't just what I was telling you, my comfort with the physical, almost comfort with the place, but with the city, but also the people at the university. There were no prima donnas. Everybody I talked to was sort of, part of the community. And they had a lot of things to be proud of and even a little bit, vain about, but I didn't encounter a single vain person. Every time I said at Duke, as I intimated that it wasn't the most comfortable existence at Duke, because it was sort of steeped in tradition that I didn't care for. Every time you would say, what we should do, you would immediately get this blank stare from whomever, and it would say, no, we've never done that before. We've never done it this way before. We've never done that before. It was, in Pittsburgh, I heard exactly the same words, but it was like, whoa, that's an interesting idea. We've never done that before, And I thought, these people are forward-looking, not looking back. And it was exactly the truth, because everybody was willing to work together, because we've never done that before. Let's try it. So that allowed me to actually do things that may have taken me a lot longer to do at Duke. So the aha moments were many, because I was allowed to do something that, I may not have been allowed to see things in the clinic, to bring things back, to say, wow, here's a reason why a patient is not responding. This is something new we're discovering. So, the difference of having a long peptide versus a short peptide, glycosylated versus not glycosylated. Recently, we probably the crowning glory so far for me was that after many years of advocating cancer vaccines in a prophylactic setting, where people used to say in conferences, would say, wait, what are you talking about? If you want a prophylactic cancer vaccine for colon cancer or breast cancer, you would have to vaccinate 10,000 people and wait 25 years to see if it works, right? And it sounds like that's a right criticism, but actually it's quite dumb, because you don't have to do it that way. There are different ways to do it. You can vaccinate a person at a high risk, whose risk can be expressed within 3 years, and you'll know, if you've reduce the risk. You can, so the thing that we just did and are about to submit for publication is we vaccinated people who had advanced colon adenomas removed and are at a very high risk for recurrence of those adenomas, and if they're missed, for progression to colon cancer. And once it's colon cancer, everything changes about the prognosis, the immune system, etc. So we are trying to prevent the recurrence with the vaccine that would then, therefore, by definition, prevent colon cancer. Not that different from an HPV vaccine that tries to prevent infection and therefore, the consequence, cervical cancer. So and this population, which are many people, we had planned 60 patients, we did 40, decided that we had enough data to understand completely what's going on, so we can just close the trial, analyze it, and then move on to bigger trials, randomized trials, etc. That population of patients, 48%, it recurs within 3 years. So you can vaccinate 40 people, or 60, let's say 20, not that. And then you can wait 3 years, and you know whether you actually have an effect. Very, very few drugs will give you that. And the vaccine, we don't vaccinate people against HPV or HBV and give them the virus to see. But this, you actually can see if something is happening. So there are many settings, and we managed to do that. And I think that the reason we managed to do this in perfectly healthy people who respond to the vaccine, et cetera, is because We drove so many other trials and showed why they didn't work, and discovered, together with the larger community, of immunologists, the immunosuppressive environment, the tumor microenvironment, et cetera. We were right there because, again, the community is open. The clinicians, my GI doc, who's my co-PI on the clinical trial, he does colonoscopies, but if you go to him and you say, we should do this, he goes, okay, let's try it. And that's what I found very supportive in Pittsburgh, supportive to many small aha moments that get you actually to your goal.